conference. We are absolutely delighted that you can all join us today. I'm here with some of our faculty co-hosts and panelists, and we are delighted to be hosting another session. Today we have the great honor of having Dr. Cara Sedney as our guest. She is an associate professor of neurosurgery and the residency program director at the neurosurgery program in West Virginia University. This is going to be an intriguing topic. It's certainly different from some of the topics we've presented before, but we're all very happy that she is joining us. So thank you to the participants and of course our guests and our faculty co-hosts and panelists. So welcome everyone, and Dr. Sedney, thank you for joining us.
Well, thanks so much, Dr. Bosch, for having me. This is a really awesome program for the spine community. It's come out of COVID, and I'm really excited to be a part of it a little bit. So I'm going to talk about stigmatizing diagnoses in spine surgery, what those are, and why we should care as spine surgeons. And I'm going to illustrate that using some cases with just a little bit of stigma theory and research at the beginning so that we have a shared framework of what we're talking about. I do not have any relevant disclosures. My irrelevant disclosures are there for completeness sake, and I will admit that all graphics are either things that we've published or I've shamelessly stolen from the internet. And more importantly, a disclaimer. So talking about stigma can make people feel bad or self-conscious, like they're being judged. But we're not going to judge ourselves today or each other. Y'all are free to judge me, I guess. But additionally, we'll have this discussion about stigmatized groups. We could talk about race, ethnic groups, or gender, that sort of thing. But tonight we're going to limit it, or I'm going to limit it to diagnosis-based stigma, and specifically stay with those diagnoses with a significant evidence base on the impact of stigma. So stigma is a word that's used with kind of increasing frequency, but what is it? It is basically a sociological process with the end result being exclusion or discrimination of individuals in a labeled group. In theory, it actually has an anthropological advantage because the group can use stigma to disincentivize unfavorable behavior, but it's well documented to be a barrier to healthcare needs and outcomes. So why talk about this? In short, it affects the care of our patients, and there's voluminous evidence to that fact for a variety of diagnoses. I'm going to take you through some of that in relation to our cases to really emphasize that stigma is something that is real, studied, and the effects can be quantitatively defined. That's usually done by social scientists. So we can predict what sort of health conditions will be stigmatized because they tend to share common characteristics. One is social danger, essentially the danger to others due to illness. So for example, infectivity in HIV or even COVID, or perceived danger from individuals, for instance, with mental health disorders. Culpability is also a highly stigmatizing trait. Are the illnesses perceived to, or are the patients perceived to be responsible for their illness? For example, substance use disorder or obesity. And then aesthetic effects. So effects on the physical appearance of individuals can be stigmatized, and it's quite easy to see those things. For instance, people with epilepsy or obesity. And then lastly, disruptiveness to society is highly stigmatizing, and we can consider, for instance, the opioid epidemic to be one of those things. Stigma for neurological diagnoses tends to be less pronounced than for other diseases because there's rarely a sense of culpability or social danger. In a comparison study of enacted and internalized stigma for various neurological diagnoses, epilepsy was found to be associated with the most stigma because of unpredictability of seizures, and that's when compared to MS or stroke. So when we consider stigmatizing diagnoses in spine surgery, we can define them by disorders that are directly treated by a spine surgeon, such as, problems with pain or substance use disorder like infections, or things that are secondary but might affect surgical outcomes like obesity and smoking. So these things might seem arbitrary, but they were listed or picked for tonight because they are both of relevance to spine surgeons and because they have a large body of literature specifically regarding diagnosis-related stigma and how it affects health outcomes that spine surgeons might not be aware of. We won't obviously talk about epilepsy today because we'll focus on the spine-centric things. In order to study stigma, we have to first be able to measure it. For neurologic diagnoses, that's most commonly done using the stigma scale for chronic illness, which has been validated for that purpose. Stigma scales tend to measure specific types of stigma. In this case, it's enacted and internalized stigma. And they also tend to center on a specific population or diagnosis. And my point in showing this scale is just to emphasize that stigma is a real thing and we can measure it. And as the field of stigma theory has matured, stigma has been conceptualized into a more cross-cutting kind of nature that recognizes meta-level effects and is not disease-specific. So we don't have different, stigma frameworks for different diseases. This conceptual framework by Stengel and colleagues was really has redefined the field in terms of how we can talk about the health and social effects of stigma. And stigma can be applied in a variety of societal levels and modified by drivers and facilitators that leads to stigma marking, so identification of the individuals. And marking of stigmatized individuals manifests in various experiences or practices, which ultimately affect outcomes for the affected populations or society as a whole. This framework is probably especially helpful for healthcare workers and for our discussion tonight because it very explicitly avoids an us versus them distinction. The phenomenon of stigma is present in relationships, not people, and therefore from a sociological standpoint, there's no assignment of blame. So let's keep that with us as we consider the cases I'll show. We'll talk about these cases in dyads, so we'll kind of compare and contrast them to help illustrate some scenarios that might result in stigmatization. So this is my first case. So this is a 60-year-old lady who presented initially to an outside hospital about 6 weeks previous with pain. She was found to have direct extension of squamous cell lung cancer in the upper thoracic spine, T2 and T3, with the first image on the left, okay? At that time, the neurosurgeon there said to radiate this lesion, and unfortunately, but maybe not surprisingly, that was not sufficient. So she now presents with the right-sided image and is weak and is status post radiation. So we can talk about what we would do. That's always fun for these kind of cases. But I also want you to think about your emotions for this case and like what you would do and also how you feel about it. Does anybody want to take a stab at it, like what you do and what your thoughts are about it?
I'll start. I think that's a great, well, first of all, I think it's a really interesting and novel conceptual framework. To be honest, it's really interesting to think about stigma. I think with this case, something that I've noticed is that I think wherever you practice, I think patients with cancer that present to the spine, I think that does have some stigma associated with it. And it's something that I think for whatever reason, many surgeons may not want to take care of or address, and I think especially for certain cancer types like lung cancer, where I think people may sense that the overall survival is not great. I think that does affect sort of people's emotions and their willingness to take care of a patient in that situation.
Absolutely. So that's a great point. And we're actually going to talk about not necessarily lung cancer. We'll talk about smoking in a little bit. So I'll just tell you my thoughts about this case. So one, it's a complex problem, right? Like the case the patient as she presented with the case on the left, like that's kind of an all right case. The case on the right is kind of a hard case now, right? And it's there's some stuff that you can't necessarily control as a surgeon. So because the patient's been radiated, so there might be biologic things that are gonna make you less successful in your surgery. And so maybe a little bit of blame there, but interestingly, we're not going to blame the patient. We're blaming, or at least I might blame the surgeon for like not just sending that case on and saying, oh yeah, just radiate it because now I have to operate through a radiated field. So that's kind of my thought in terms of like how my thought framework for approaching the case. I don't know. This is what I did. I just did it from the back and took a couple nerve roots and did a corpectomy. But the importance is like what you feel about it. Okay. And this is actually the less stigmatizing of the two of the dyad. Okay. Here's the next one. So this case is going to have similarities in some key aspects. This is a 43-year-old female. She has a history of IV drug abuse. She presents with pain and is found to have the image on the left. She is neurologically intact at that time. You start a workup and you have a frank discussion with her regarding risks of surgery. She declines surgery and then leaves AMA and then returns 8 months later with the image on the right. So, how would you deal with that? And then more importantly, how do you feel about this as compared to the other patient?
Yeah, so I'll take this, I guess. So I'm a little off balance because I don't know exactly where we're going with some of the stuff you're talking about. But what is the neurologic status of this patient?
She's weak now. She's weak bilateral lowers.
Okay. Yeah, I mean, I mean, the issue with this case, I mean, obviously they would benefit with, you know, with some surgical help. The issue is just the history, the drug use, can they handle the surgery? You know, it's clearly going to be not a small surgery. We can talk about kind of what the options are and how to approach it, but you know, the hesitancy to even operating is going to be, I think you're probably forced to if she's getting weak, right? I think we all would if she's getting weak, but certainly the way you feel about it is you feel differently, right? Because you know you're going to have some issues, whether it's compliance, follow-up, wound opening up, you know, when they're somewhere else, versus, you know, you're going to have issues with the tumor case as well, but those issues you are a little more empathetic to. I think most of us kind of innately are a little more empathetic to that patient because they're not leaving AMA and they have a diagnosis that they didn't ask for and all that other stuff. So I'm not saying those are right or wrong, but I do think we probably end up feeling differently about the cases.
Yeah, absolutely. Thank you for that. That's exactly what I was getting at. So we kind of, we might feel that the patient has, it's a little bit their fault, right? Because substance use was probably the inciting event for this infection and left AMA, and now is back with neurologic deficit. It's like you said, a complex surgical problem. If it was easy, it might be less straight. And the things that we can't control are maybe more behavioral and less biologic. And also, like, for me, the volume of this problem, like we probably do, I don't know, my last call, I did like 3 thoracic corpectomies for discitis. You know, it's like never ending. And also just the fact that it is a societal problem. So, you know, I end up worrying about my kids, right? Like, are they gonna have this like entire generations have had in West Virginia? So those are all the things that kind of like go through your mind. And I think that these are two good a good case dyad, because it's something that's a little bit less stigmatizing and then something that's a little bit more stigmatizing. And then sort of secondary to the purposes of this talk, but just because it's a case, so this is what we did, again, sort of just a multi-level corpectomy and try to reduce the kyphosis. So that's our first set of substance use disorder cases. And there's some of the points that that you brought up. So thank you for that. So another case is deformity. So this is a 56-year-old veteran. He has pain, but mostly positional complaints. And this deformity partially reduces over a bolster. So in general, what do you do and how do you feel about it? Anybody want to take a stab?
Yeah, it's Ali. Thank you, Cara, for these cases. I mean, you know, the first feeling is like, wow, right? This is going to be a tough case. This is going to be challenging. A lot of potential post-operative and perioperative complications. I need to talk to all of the family. We need to have several, you know, meetings to discuss surgery. So this is a major undertaking that's going to take a lot of time from multiple clinic visits, as well as potentially a significant perioperative kind of follow-up and fraught with potential complications. That's how I look at these.
Fair. Yeah. So for me, because this is flexible, I'm a little bit excited about it. I think it's going to be a fun case, but that definitely, you know, maybe some cussing going on during the case. The fact that his main problem is positional complaints makes me a little bit happy. And again, the fact that it's flexible makes me a little bit happy. And just for follow-up, I think I did like a 3-level lateral and just long fusion on that. So that's the less stigmatizing case. So here's the more stigmatizing case. This is a 48-year-old woman who had previous opioid use disorder. She is now on Suboxone, but occasionally injects meth for her back pain, which is longstanding. And you can kind of see on the Scoli films why she might have back pain. She presented for worsening pain that was associated with secondary infection of the hardware that you can see there, and you can see the loosening of the hardware. So again, what do you do? How do you feel? Do you take out the hardware and call it a day? Do you or would you ever try to fix this deformity? What do you guys think?
Any takers? Who's with us?
Sorry.
Nader or Michael?
Yeah, Cara, what are her main symptoms?
Well, she's got infected hardware, but her main symptoms right now are back pain, which is worse now that her hardware is infected.
Yeah, I mean, obviously something like this is going to require fairly large, extensive revision surgery. I think if this patient came into my clinic, it's obviously it's not an emergency operation, but the thing that I want to ensure is that the patient's completely invested in the complexity of what needs to be done. So that's what I try to get through patients, unless they're neurologically decompensating, which it does not sound like she is. I think it's of the utmost importance that the patient is completely invested in their care and don't think they're just going to willy-nilly walk into your office. You're just going to fix them. They've got to understand that this is fraught with a lot of complications potentially, and that there's going to be a lot of issues with pain control after. You said she's on Suboxone, chronic opioid user. So all of these things, I just try to get out in the open with the patient, from day one with them prior to undertaking a big operation like this. Because if they're not understanding of what they're up against, they're going to be very unhappy, even if you can make this picture look pretty.
Yeah. And so that's, thank you for that. I completely agree. So, the stigmatizing aspect of this is obviously the substance use disorder, but that comes along with some real issues, right? And so for her hardware is infected, that has to come out. But I personally told her that, I would maybe fix her deformity if she could come and see me like for the next year and not be injecting meth. You know what I mean? Like, I don't know how to do a big complex surgery on a patient that is maybe a chaotic user and unreliable and doesn't come to clinic. You know what I mean? So I think that it's really, really a hard thing. And maybe acknowledging that the care is different, but maybe not, maybe it's safer. So that's the more stigmatizing case. Definitely not excited about this case. It's gonna be, you know what I mean?
Well, it's going to come on you, right? If something bad happens. So, right. So that's why you got to make sure that the patient's completely invested in this.
Yeah.
So,
Yeah. And I'll tell you, I have not seen her since I took her hardware out. So that was not a discussion that held a lot of weight with her right now. Maybe it will someday. Anyway.
maybe she's getting more flexible.
Huh?
So maybe she's becoming more flexible.
Yeah, I wish. That would make me excited. I have a feeling that's not going to happen. So I put my references here on the slides just for at the end of each diagnosis, just to emphasize that I'm not just like making stuff up. There actually really is good evidence to back up stigma. So substance use disorder is obviously a huge problem in the United States. I think all of us as spine surgeons are seeing the manifestations of that, which are usually from unsafe injection practices leading to infectious complications. It's also important to understand that stigma itself is a determinant of these poor outcomes. This stigma has a variety of drivers, including perceptions of culpability, dangers to the public, think of dirty needles in the community and that kind of stuff. And really the only medical treatment for SUD that's proven is medication like buprenorphine. And even that has stigma associated with it and is vastly underutilized nationally. So for instance, when we try to get our rural community providers to increase their Suboxone waivers and things like that, their X waivers, they verbalize classic stigmatizing beliefs about the treatment for the stigmatizing diagnosis as reasons that they won't provide MAT and they won't learn how to do it, even if we try to pay them to sit through the training. And so it's pretty deeply ingrained. The enacted stigma of healthcare workers on people with SUD actually reduces those people's engagement with the healthcare system. They anticipate that they will be stigmatized, and that is a major reason that people with SUD fail to seek care in a timely fashion. All of us here tonight know what that looks like. It's evident in, the language that we use, the treatment strategies that we employ, everything from, not letting patients off the floor and prolonged hospitalizations or inadequate pain control, clean or dirty descriptors, or even just overt hostility by healthcare workers. And that's very well described in the literature of people. When you talk to people with substance use disorder, they have all these experiences and are very aware of the sort of negative traits that are assigned to their group as substance users, like being a junkie or things like that. And that actually can play into their own self-efficacy with respect to sobriety and contributes to not coming to the hospital even when they need to. So when you ask yourself, why did this person like wait until they were paralyzed or wait until, 3 days or 3 weeks after they couldn't walk before they came to the hospital? The answer is that they're afraid of us. They can, they do not want to come to the hospital and have people treat them like they're awful people. And that's just the reality of it. Having said that, it's also important to acknowledge that there are real care difficulties in caring for these patients with SUD and spinal disorders. And these are things that can result in poor outcomes and also compound the poor outcomes. And we've published on this. We, have a huge number of surgeries in our patients with substance use disorder, large number of complications. Like half of our patients with substance use disorder were known to continue to use drugs after discharge. So we're not good at this. And so it's really easy as spine surgeons to get frustrated with it. I'm not sure what the answer is for some of these situations, particularly these like emerging populations of people with substance use disorder with non-emergent spine problems, or even substance use disorder in remission. I don't think there's data there for that emerging population, but I think that one thing we can do as spine surgeons is not make the situation worse with stigma, like recognize those stigmatizing beliefs. It's not the patient's fault, it is a disease. And half the time when they leave AMA, if you ask the patients why they're doing so, they are doing it because their pain's not controlled, they're withdrawing because they aren't getting medication that they need, or some of them have like a court date or something like that. It's like a social reason that they have to leave. And so knowing that stuff can improve their care, certainly, and make the end outcome better.
Hi, Cara, this is Ali. Just a quick question.
Yes, sir.
Sorry to interrupt. Obviously these cases and these topics are very important to us as surgeons, as attendings, as faculty. I mean, we're responsible for the patient. We think about the long-term outcomes and everything. You're obviously part of a training program, and a lot of the folks here are as well. What do you think this also impacts our trainees, residents, and fellows? Do you think they're biased, or they look at these diagnoses with a certain stigma? And what can we do better as teachers and educators to ensure that our trainees are kind of taking these into consideration?
Yeah, that's a great question. I mean, I think that the best thing that we can do as role models for our trainees is role model appropriate care. So, trying to not, if you have, try to see that person as a patient. We'll talk about some ways to mitigate stigma and things at the end. But I think that role modeling good care, and sometimes like you might find a trainee say something like, oh, that person's, a dirtbag or like whatever. And like, they're probably just tired. But calling that out, you know what I mean? Like, that's not okay. It's a person, I think those little kind of daily interactions are the best way, honestly.
Yeah, no, that's absolutely right. I think you're right. Being a role model, we have to, especially for vulnerable patients, for patients with difficult diagnoses, what we say and what we do and how we say it and how we do it, the trainees will literally mimic that. And so it is very important. Michael, I'm sorry, I cut you off. Michael Galgano, were you going to say something?
Well, that's okay, guys. The question I had for you, Cara, is if there's any type of a substance abuse fast track program that you or any of the other faculty or hosts have at their home institutions, because what I find up in upstate in Syracuse is that these patients come in, we get a ton of these osteoepidural abscess cases, and as soon as they're able to walk again, they're either leaving AMA or we're trying to dump them back on the street again because they're unruly to the staff and doing whatnot. Should we be kind of thinking, rather than getting rid of them, should we be trying to capture them and get them into addiction psychiatry program or something along those lines? Because in Syracuse, we've had a very difficult time actually holding on to these patients. Once they leave, and we have very poor follow-up with them, as I'm sure you guys do as well.
Yeah, absolutely. That's a great question. Yeah, our follow-up is awful. I think in our series of patients, when we looked, we had like 20% of patients left AMA and another 30% never followed up after they left the hospital. And just for clarity's sake, we keep these patients with serious infections inpatient for the full 6 weeks of antibiotics that they need, because there are issues with discharging them. I know some centers, particularly in Boston, are trying to do outpatient therapy and have data that I think they presented but haven't published yet, that if you send a patient with substance use disorder out, they're not going to mess with their PICC line. They know how to inject themselves, and if they need to use, that's what they'll do. But we've been keeping them. And our hospital probably 5 years ago, went through like a lot of soul searching because it was started up by an ethics consult where a woman came into the hospital for a 7th spine washout, and she kept reinfecting her spine because she kept leaving AMA and using. And so when we really looked at it, the reality is that we were treating her spine infection, but we were not treating her substance use disorder. It's like, you know, not treating the diabetes that causes someone's amputation and wondering why you have to amputate the other leg. And so that was really a formative case for us in our hospital, and made us really beef up our inpatient availability of substance use disorder treatments, including we have inpatient group therapy, we do inpatient partial agonist therapy. And so when you talk to these patients, because we've done this too, we've done qualitative research looking at these patients, and when you talk to them, the reason that they leave is their pain's not controlled, they're withdrawing, they're not getting the agonist therapy that they need to not withdraw. They can control their pain better at home with drugs. They're bored, or people are assholes to them. You know what I mean? People are inappropriate to them, and they may be mean to the staff, but often it's bi-directional. You know what I mean? And that has a big part of it. And so that's like an example actually of stigma impacting the care. Does that make sense?
Yeah, absolutely.
Okay, so I started with like a heavy hitter, I guess. We're gonna keep moving. So my next case is an extension fracture. This is the less stigmatizing case. So this is a 78-year-old male. He had a car accident. He's got an extension fracture. What do you do? How do you feel?
Okay, I'll comment since I haven't made a comment yet. So, so yeah, absolutely. This is an extension type fracture in the setting of probably dish. And how old is the patient? And did he come in like to the emergency room, or he happened to be mobilized and was lucky enough not to get a deficit?
Yeah, so he was a car accident. He was a trauma page. So he was
trauma page. Okay. So I mean, you know, does he have any comorbidities, or what's his exam?
He's intact and otherwise generally healthy. He's like, you know, typical rural farmer guy, doesn't really go to the doctor.
So I mean, then as you mentioned, that's a pretty straightforward case. You just need to make an assessment on how stable is his spine. Obviously it's not, and you got to offer the patient the right thing, which is a long segment posterior fusion for this, so that he can be mobilized in expeditious fashion and discharged. And the goal of the surgery is to stabilize the spine, avoid the neurological deficit, and fast mobilization. Yeah, go 3 up, 3 down, and then mobilize him with a brace, and that's about it. Discuss with him the usual potential complications, mainly wound breakdown, and these patients, for some reason, sometimes they got a wound dehiscence, and they heal pretty well. There's nothing to reduce here. That gap here will fill with anteriorly, at least, with bone, and they usually heal well.
Yeah, awesome.
Yeah, to me, this is a perfect case for minimally invasive surgery. So yeah, percutaneous fixation of these is great. And you've just got to use a few tricks to get reduction on the table. So you're using a Jackson table, they tend to sag into it, so the extension gets worse. So if you've got a radiolucent Wilson frame or one of those nice Proaxis type tables, you can get a better reduction by actually keeping the patient kyphotic when you fix them. Complete reduction isn't essential, but it's nice to have some form of bony opposition here. And I use cement in all these because they're often very hard bone on the outside, but soft bone on the inside. So they're porotic. And so 3 up, 3 down, agree, but I would do this MIS with careful positioning and cement augmentation. The other thing I always like for these is a full spine MRI, because I always look for the second fracture.
Yeah, thanks for that. I guess I'll just add my stuff. So for me, if it's we see a ton of these, if it crosses the TL junction, I definitely will do it perc, long segment. If it's thoracic, I feel like it kind of toss up half a dozen of one, 6 the other. So and I don't personally do much of the cement augmentation, but I definitely try to fill the pedicle. But anyway, that's just me. But that's like secondary. It's like the less stigmatizing case. Okay, here's a stigmatizing case. So now, how do you feel if that exact same patient is 40 but has a BMI of 78 and weighs 700 pounds, and your Jackson bed is 500-pound max?
So, Cara, this is fantastic, and I tell you, firsthand experience. So, how much does he weigh? 700 pounds?
700 something, yeah.
700 something. So the Jackson table, the maximum weight, I think, at least here is about 500 pounds.
Yeah, ours
so,
too.
So that's number one. Now, like we know the patient's the spine is biomechanically unstable, but it's everything's risk benefit. Like from experience, I had a patient who was not as big, probably around 500 pounds or even 460. We were able to position him. Problem is we were not able to ventilate him. His peak airway pressures were really high. So it was an impossible surgery. And actually I had a patient, arrest, but he survived. And long story short, I treated him with recumbency, because the surgical risk was really high. We tried to do an operation on him, but it was, they were not able to ventilate him because of he's so heavy, and the inability to ventilate was an issue. We tried a couple of times, brought him back and tried to do different things. But since this technically probably it was possible, but like just ventilating the patient was impossible. I ended up treating that patient with recumbency, which is definitely the road less traveled. What we do, Lovenox and recumbency for months, and then we were able to mobilize him after he has healed. So that these are my thoughts. I mean, you gotta, definitely make every effort to do the right thing for the patients. But sometimes, like if a patient's 700 pounds and the table can hold only 500 pounds, so you gotta be either creative as this image shows, or just I would treat them, probably with recumbency if the operation is impossible.
Yeah. So I'll.
Cara, sorry to interrupt just real quick so we can get some folks on the chat box here to get some of their input. So Cara, and by the way, I'm going to come back to Mike Selby a little bit and Alexander. But first, Dr. Yam, David Yam, our good colleague from Washington, asks about lateral, right? A lot of people have discussed doing these cases in a lateral position because some of them can't tolerate the prone, either for fracture instability or weight or whatever the reason is. Cara, can you comment on that, please?
Oh, I mean, you're braver than me. I don't personally have experience doing like instrumentation in a lateral position. You know what I mean? Like inner bodies, yeah, but I don't personally have that experience. It definitely would get rid of the ventilation problem, but I worry about compressive neuropathies a lot, doing that. But it's a great idea.
Okay.
Braver
Yeah, I have. It is brave. I've done it once. I've also had colleagues who've done it for patients who just, despite using the chest rolls or the Wilson, their ankle spondy fractures just too unstable. But that's definitely an interesting thought. But Cara, I apologize. I'm the bad guy here interrupting you. But I want to get thank you. I want to get the perspective of both Dr. Selby and Dr. Mamagani. There are our panelists here on Virtual Spine. Dr. Selby is an orthopedic spine surgeon from Australia. Dr. Mamagani is an orthopedic surgeon from Switzerland. So Europe, Australia. I want to get their opinion on the first part of your talk, which is, or really the entire talk, which is the stigma associated with some of these diagnoses. You mentioned, obviously where you are in the US, we have a lot of experience with this. Mike, I'll start with you. What are your thoughts on these topics that Dr. Sedney is presenting in Australia? How do you guys and gals handle that, these diagnoses, drug abuse, multiple washouts, patients who are, what do you guys do? How do you guys handle that? Let me just put it that way.
I suppose from a societal perspective, Australia is really similar to the US. So we're very similar in terms of our mix of patients, and we have a lot of patients with obesity and drug and alcohol issues, and diabetes is rampant. It's you know, we are fortunate in that we have a public-private mix. So a lot of our surgeries are done privately, but we've also got a big public hospital system. And something I thought about for the previous case with the IV drug user and the fusion that had failed, and is that sort of patient we can actually admit to our public hospitals for a long period of time and almost do a prehabilitation, workup, withdrawal, and then actually put them through the surgery, which is all government funded, rather than being under financial pressure. So I suppose having that mixed system means that we're not under pressure to only pick well patients to operate on. And we do have some facility to admit patients for weeks or months for these big procedures. I suppose that'd be the only real difference that I see in the cases and presented so far. We have the sort of same stigmatization and issues with getting things done, but we do have a few little ways around that that our system allows, I think.
Got it. Thank you for that. And Alex, how about you guys in Switzerland? I know everything is perfect there, but what are your comments on that? How do these challenging cases and kind of really unfortunate and sometimes difficult patients present, and how do you guys handle that?
Yeah. Thank you for this question. It's really different here. Many greetings from Switzerland, Cara. I follow this conference since a month, and you were asking the most difficult questions, like how do I feel when I see these patients? Usually we are talking about technical aspects, but it's really hard. I can tell you, Switzerland has got a high number of people with drug abuse, with addiction. This is a little bit due to the law. It's very liberal here. It's not a hard punishment. People are not hidden. They don't have to hide. They get a full support for their community. Like Switzerland is 8 million people. We are a village if you compare it to the US. And so everybody knows each other, and we have got many doctors, many physicians, many family doctors. And these patients, you have shown the first part of your talk, they are not sent to us, or they don't come to the emergency room without any medical advisors. They have got a doctor, a physician, often infectiologist, because they are HIV positive. There are family doctors who are specialized in addiction medicine, or psychiatrists, and they have got a long history and they are well known. I work in a public hospital, and we don't refuse anybody. We treat everybody. This is our the government has given us this task, and we do this and we fulfill this. But for you to talk about my emotions, they lie a lot to me to get substances. And when I do a prescription, then I notice 1 week later that 4 other physicians made prescriptions for opioids as well. It's hard, but we treat all of them. They are not homeless. They live in an apartment. They have a room in special homes. They don't live on the streets. They get money from the government. So Switzerland is a little bit a good place to live, even if you're drug addicted. And we have had some tourism from other European countries around Switzerland. But I want to point out, I can't do these patients, I can't treat them alone. You have to have friends from family medicine, infectiology, all these other parts in our hospital. We have them, and I'm very glad to have these colleagues, because alone I will really be annoyed and emotional in immense stress, and I will not manage.
Thank you. Thank you, Alex and Mike, for those perspectives. Cara, sorry to cut you off. Go ahead. Let us know what you did in this case.
Oh no, thanks for those things. That's super interesting, particularly about the sort of the different system in Switzerland. So for this case, so first, how I felt. I mean, I can only describe it as like, oh my God, but it's just because it's hard. It's a change in our whole, OR protocol. It's high risk. The patient may not do well. And so, you know, there's definitely a feeling of like, my God, you know. But this guy didn't do anything different than the other guy. Car accident, he was just driving. And so just, you know, for practicality's sake, we decided that, you know, our Jackson frame, the limit was 700 or 500 pounds, but I think our Wilson frame, the limit was like 650 or something like that, if I remember correctly. So we strapped the Wilson frame to 2 Jacksons and strapped 2 Jacksons together. And then we had to flip the C-arm up to do it. We had to do an AP to find midline because you can't feel midline. And definitely didn't try to do this perk, obviously, like, because we wouldn't be able to see anything or we radiate the crap out of ourselves. And I don't know if, obviously there's not like safety standards or whatever for strapping 2 Jacksons together, but I guess you kind of have to consider like your own. So that the problem with this is that you're so far away from the patient. I had to like kneel on a table. And so I think I probably needed to like include my body weight in the overall body weight. Because we literally had to operate kneeling on the table on this guy. But it is hard. And so like the point is that obesity makes a difference in spine surgery. You have to like change all of your protocols for pre-op, intra-op, post-op, and it's hard. But it's also important to understand that obesity is stigmatized. Okay, it's obviously extremely relevant from a health standpoint, including spine surgery because of the effect on our outcomes and because of technical difficulty, just like that case. But obesity is probably the most highly stigmatized condition in many modern societies because of that belief of culpability. In many societies, overweight is associated with lack of control or laziness, and it violates a social norm. It's visible, it's very obvious, and it has an aesthetic effect. And in many studies, stigma for obesity is even more pronounced than that for race or ethnicity, which is pretty striking. Obesity-related stigma arises in socialization before kindergarten when we study it in behavioral studies. And stigma for weight is openly expressed while other stigmas might be repressed. So like think of, you know, the fat joke, which was until pretty recently considered kind of acceptable, you know. And healthcare workers are really not immune to this. In a survey of 2,000 physicians, there was strong representation of implicit and explicit bias against overweight patients, and this actually increased on an updated survey of these physicians. It didn't go down. And physicians report reluctance to perform certain aspects of the physical exam on obese patients. And this enacted stigma is actually perceived by patients. They in turn report that they believe their clinicians would not want to treat them. And obesity related stigma affects patient care by directly influencing their self-efficacy and motivation to change their weight-related behaviors. So their motivation to lose weight decreases as they are exposed to stigma. And it also creates changes on a physiological level. It actually increases cortisol that can perpetuate the inability to lose weight. So that stuff's pretty crazy, but it's important to know because it definitely can affect health. So next we're going to talk about pain. And so here's my less stigmatizing case. This is a lady who has back pain and radiculopathy. She's had multiple kind of decompressive surgeries, foraminotomies type of thing, and has really bad leg pain and some bad back pain. You can see her myelogram there. I forget why she had to have a myelogram, and then her upright x-rays. So thoughts about this and what people would do?
Nader, what do you think? You see a lot of these patients,
Yeah.
Degen lumbar. What are your thoughts?
Yeah, sure thing. I mean, so these are now elective. We're talking about elective cases. So definitely, you gotta ask how old is the patient and what's her bone health status if she's older and she's a female. You know, we gotta take our time optimizing all these potential variables that can be improved upon. You know, the bone health, and make sure that she has diabetes. The HbA1c should be optimized, and then if you in your mind you think the risks of an operation are outweighed by the benefits, or the benefits outweigh the risks, then you proceed. Given that you identify the pain generator, looks like she has a spondy L4-5, probably she has foraminal stenosis, pretty focal pathology. You know, the right treatment is probably a TLIF, but even if it's a small operation, if the bone health is not optimized, and you can start the fire and causing more complications down the road. I mean, I've seen patients with a single level TLIF and osteoporosis. Start with that, and then you end up with a T4 to the pelvis down the line. So, so in this situation, it's an elective case. You have your time to think about it, identify the source of the pain, and then optimize all these modifiable risk factors if they exist.
Yeah, perfect. And so this lady was actually the perfect patient. She was active, not osteoporotic. She's, in her 60s, but like a young 60, and yeah, so what I feel about this is I can see what's wrong, and she has a radic. It's not just back pain. So like that makes me like happy, and so I did a TLIF on her, just like you said. Now for the more stigmatizing case, all right, this person just has axial back pain. And the x-rays, there's no trick here. The x-rays don't show something that the MRI doesn't show. So what do you think? And what do you feel? I
feel that there is hope for this patient too. even if the answer is not surgery. I mean, as spine surgeons, we don't have to offer every single patient an operation, and we still offer them treatments. Like even if you don't offer an operation, you're still offering treatments by counseling them, by trying to help them identify where the source of the pain is coming from. And, if it's mechanical or if it's myofascial, if it's facetogenic, sometimes, you look at the CT scans or the MR and you find like there's some stir signal in the facets, and you tell them, yeah, that's probably the source of the pain. We're going to try to do a facet block and then probably an RF ablation. So, my feeling is I don't want to be dismissive with any patient, even if I'm not impressed by their MRI, if I think it lacks a structural source for the pain. And even if the patient's overweight or obese, you got to make an effort to help them, show them that you want to make an effort to find where the pain is coming from. Sometimes they have pain and the source is subtle, yet structural. And if just that's my feeling. It's there's hope, and want to make try our best to find where the pain is coming from, and even if it doesn't need an operation to address where the pain, there are still treatments that can be offered for this patient that are non-surgical.
Yeah, that's perfect. And so we'll actually talk about the importance of finding the source of the pain and talking to the patient about that in a second. And yeah, that's a perfect answer. I totally agree with you. I think that seeing this kind of image in your clinic kind of makes you tighten up, like, oh, I'm going to have this big long discussion. They might be mad and they might be this or that. And, probably all of us have like a visceral reaction to like these pictures. You know what I mean? And there's a lot of reasons for this. Sometimes these patients are really difficult for us to help. But pain-related stigma is really relevant to this problem. And so because we see a lot of pain in spine, it's important to understand the drivers of pain-related stigma. And so I'm going to give you guys a little history lesson that I think is really interesting. But first, it's important to notice that even the Latin root for the word pain means punishment. So I think that's instructive to us as how we as a society view pain. And we can relate our current sort of pain-related stigma actually back to the 18th and 19th century, which is when Western medical thought embraced what's called the mechanical objectivity paradigm. This means that a person experiences pain, and when they do that, there must always be a material disease explanation for that pain. And so my example is a historical thing that I'll show in the next slide. But ultimately, though, I think it's important to know that mechanical objectivity paradigm continues today. We want to know where the pain is coming from. Health has been shown to underestimate pain and to evaluate patients' experiences of pain when that pain occurs without a medical explanation. And that's been demonstrated in everyone, medical students, nursing students, nurses, physicians, physical therapists, and the general population. And almost all of us can probably think of a situation where we personally have sort of done that. I don't know where that pain is coming from. Is it even real? And both general populations and healthcare professions feel less sympathy and dislike patients more and suspect deception more in these patients. And it's especially noticeable in chronic pain as opposed to acute pain situations. And it's been shown to affect the relationships of patients to their care providers. And Scott and colleagues have noted that stigma, punitive responses, and perceived injustice relating to chronic pain may increase pain. And it can increase pain-related disability, whereas conversely, supportive social environments can foster well-being among patients with chronic pain. Now think about that. and the implications of that for things that we deal with every day. So for instance, think about surgical outcomes in work comp patients, because those patients, in fact, have worse mental health, poor rehabilitation outcomes, and prolonged work disability associated with more perceived injustice related to their injury. So stigma can actually affect outcomes in ways that are relevant to us. And the enacted stigma of chronic pain is experienced from everyone. On the patient side, they experience it from their romantic partners, their friends, their family, their healthcare providers, and even themselves. Because our mechanical objectivity paradigm is so ingrained, it actually serves as a driver for self-stigma of patients with pain, and they doubt the validity of their own pain complaints when it can't be traced to a specific cause. So like, that's why when we say, or if someone says, oh, there's nothing on your MRI, they're mad. Like they think then that like they're questioning everything about their own symptoms and think that you are too. So that's really important to notice. And the historical example is in what's called railway spine, and that kind of fed into the mechanical objectivity paradigm. So railway spine was a diagnosis that became medical legally relevant in the 19th century when numerous railway accidents were litigated due to causing back pain. And medical consultants in those cases were expected to raise doubt as to the veracity of the complaint if no concrete medical findings could be found. Now, keep in mind, this is like in the 18th and 19th century, so there was like literally no medical diagnostic testing available. And so physicians, and then as a result, court findings, even up to state Supreme Courts, determined that pain complaints without material substantiation were linked to other undesirable or socially marginalized traits. For instance, in this case, Abbott v. Tolliver, the plaintiff's pain in this case was attributed to her being female, overweight, and unchaste. That's literally what the court finding said. And so that's kind of a beginning to how we view pain and how we need to link pain to a thing that is visible to us. And so I'll say that I agree with you in terms of how to deal with those patients trying to find a cause. And I'll literally look for anything on that MRI and be like, well, there's some degeneration here. Not that we operate on that, but that can be a cause of pain. And so we just need to look for, where it's really hard to tell a patient their MRI is perfect when they're having symptoms, or that there's no explanation for what they're feeling. Any thoughts on that part of things?
I think, yeah, I mean, now it becomes like more art than a science too, in terms of handling these patients if they happen to come to your clinic. I mean, hopefully, at some point, the triage process becomes better, and the better utilization of physiatry and patients who have near normal MRIs. But yeah, I mean, it's you gotta be empathetic, not dismissive, and educate them. Some of them they just need to be educated that there are things that can get better or without an operation. And the problem is I mean, the challenge is you got to spend a lot of time with them. I mean, these patients, you talk to them longer than you talk to a patient sometimes who needs really like a big reconstructive surgery.
Yeah, absolutely.
So, yeah, but
thank you for that. So here's our next to last case. So this is a isthmic spondy. So patient has some radicular back pain complaints, failed conservative therapy. What do you feel about it, and what do you do about it?
Dr. Goodwin, I'm going to pick on our good friend Dr. Goodwin here. What do you think? This I don't see much stigma with this case. So this is a beautiful spine case for most spine surgeons, I would say.
Yeah.
Well, first of all, I think I have much less feelings than everybody else here because I don't feel much about most of these. But yes, I mean, sorry, they have radicular pain. Is that what you said? Yeah. So how old is this patient?
I don't know, like 40.
Yeah. So I mean, I think it clearly can be it can be a surgical case. There's probably a more stigmatizing case following on the back of this, like the rest of these. The only comment I was going to make before we move on is that, yeah, I think the real challenge is what Ned or somebody might have just said about how ideally we wouldn't have all those patients in our clinic, right? We're all going to be good physicians, but the problem is you become not a surgeon if you're spending your time doing non-surgical care. And so I think the trick is, like, I'll tell those patients, and I don't know if this is right or wrong, but I'll tell those patients, hey, I don't think you have a surgical problem. You definitely have back pain. That's very common. And if you see enough of us, somebody's going to operate. And I would not do that. And I try to tell them, hey, and that could ruin your life. You know, if somebody starts operating on you, we know now that there's a lot of reasons for. And so I try to give them that talk of like, hey, just like, I'm worried about you. Be careful, because there's people out there that'll put hardware in you. Mm-hmm. So anyway, so yes, I think fusing this is reasonable. I think there's a lot of ways you can do this that we can talk about, whether you need an interbody or not, or whether BMP is sufficient, and whether you fuse the pelvis or not, are all things we can talk about.
Yeah, and so I'll just keep moving, because it's probably something that you guys have talked about ad nauseum a little bit. The point is the second one. So this is the exact same case in a smoker. Now what do you do, and what do you think?
May I ask you, how high is the percentage of smokers in the US at the moment?
I mean, in West Virginia, it's probably like 30 to 50%.
Yeah, it's a female higher than male?
I don't honestly know.
Because in Switzerland, the percentage is very high. In some ages, like 50%. The younger female are the heavier smokers at the moment. But I think if the patient is a smoker, and I have many smokers, this is nothing I can change immediately. I always ask them to do a stop before surgery, and I don't know for sure. I can't measure it. I don't know how many lie to me if they say, yes, I managed. And they in hospital, they are really nice to me, and I don't see them smoking. But after they left, I don't know, and I don't treat them differently whether they are smokers or not.
Yeah, perfect. I mean, I think some people are really sticklers about it. Some people don't. I personally don't make people quit before I'll fuse them, because I would never operate if I did. But if they have a pseudoarthrosis, I'll make them quit before I fix it. Sorry, was somebody going to say something?
Yeah,
I don't.
Yeah, go ahead.
Sorry, guys. I don't fuse smokers. I refuse to.
Yes,
I think the results don't.
I have made the experience that if you refuse to do this, they go to another one and another one, and at least they will end up in a private practice. I'm in a public hospital, and I don't see a difference in our society for smokers or non-smokers, and I can't judge them for their lifestyle, but I admit there's a higher pseudoarthrosis rate. Yes, it is.
So for me, this patient has to stop smoking, but I tell them, like I do a lot of things, like, hey, it's the nicotine. We think it has something to do with the bone healing, and you know, if you go back smoking in a year when you're fused, you know, I'm not here to talk to you about your lungs. I want your bone to get better. And we do a urine test for that. But I've been surprised and amazed, at least in Missouri, how many people will stop smoking when they have bad pain and will fuse, and we test them. So.
Yeah, I agree. I mean, I think going back to getting the best possible outcome for an elective operation, smoking cessation is like a pretty basic. The thing is, it's not only for the pseudoarthrosis purposes, it's also for general health. Like, you know, you get atelectasis and pneumonia, you know, stuff that that's related to smoking, a sick lung, like even you got to stop for at least 6 weeks and a negative urine nicotine test. Like, for instance, if you stop for 2 weeks, it's even worse, because that's where the, you know, peak lung injury can happen. You got to stop for 6 weeks. So that you know, trying to kind of optimize those patients' outcomes as much as you can, not only for the pseudoarthrosis purposes of like achieving a healing purpose, but also for just avoiding like a post-op atelectasis that goes to pneumonia, prolonged hospital stay. I mean, these things come to my mind, and when I see a smoker, it's like, you know, you want to run a marathon, right? Like you want to prepare for it. You want to be in the best shape possible. Smoking cessation, optimizing your BMI are the two things that one can do to help make it a success.
Absolutely. Thanks for that. So There's tons of practice variation in that, but the point I just want to make from this is that smoking denormalization is actually intentional stigma, and it's working to decrease smoking. But it's also important because that long-term stigma from healthcare providers can actually impede patients' healthcare. When we survey healthcare respondents, we find that they are less likely to refer patients for lung cancer treatment than they are with breast cancer. That's crazy, right? And we may or may not to change our decision to operate on a smoker, but understand the repeated downstream effects of stigmatization by healthcare providers is directly associated with psychological distress, avoidance, or delay in medical care. So just recognize that if we're delaying care until they stop smoking, that can actually influence their ability to seek care later. So that's all I'll say about it. And then what are things related to stigma? So one thing that we've studied is that stigma is related to burnout, which doesn't create stigma, but it can unmask stigmatizing beliefs. And so that becomes relevant in all the cases that we've talked about, because these are like, difficult to treat cases, increased liability, increased risk, poor outcomes, stuff that we can't control as surgeons. So be mindful of that when you're interacting with patients. And we can actually modify stigma, particularly in terms of thinking about it and not doing it, and trying to see patients as people. And so there's a couple ways that we know can change stigma. One is educational interventions. So just increasing awareness, because that can sort of alter some of our unfounded beliefs about treatability or risk or blame or communicability. And so really trying to understand that and centering the disease process. So like obesity as a disease or substance use disorder as a disease. Another thing that works is patient-centric communication. So intentionally separating clinician level interactions from societal or public health concerns. So yes, substance use disorder is a huge problem. Don't let that affect your care of the one patient. And the Lung Cancer Association has done a great job with this in terms of sort of divorcing those two things in their advertising campaign. No one deserves to die of lung cancer, even if they are a smoker. Empathetic communication, like Dr. Cara said, is another one that's very important, and it's worth mentioning because we often miss it. And the last thing is just internalization of counter stigma themes, and just realizing that we can mean well in what we say, but actually what the patient experiences isn't necessarily what is carried out by what we say. Last thing that can help with stigmatization is team-based care. We've sort of touched on this. Obesity, pain, and addiction. I don't know how to treat pain post-operatively in someone that's been shooting up heroin. I can't do that. My pain doctors do that. And so just leaving the heavy lifting of that kind of stuff to the people that are experts is really important. If anybody wants to read anything else about it, I think our paper comes out in World Neurosurgery this month. And so we have a little table of different ways to decrease stigma in neurosurgical care. And what I just want to leave everybody with is that, for diagnoses that are prone to stigma, I think it's valid to say that they may have a poor outcome or are frustrating to care for. Sometimes stigma itself can actually influence the poor outcome. And so I hope that people will consider that when caring for patients with some of these disorders. Thanks.
Thank you. Thank you so much, Dr. Sedney, for this presentation. I mean, obviously, just from the discussion and the interaction, it's obvious that we probably need to have another session or two on this. I mean, this was absolutely eye-opening, and it really is important. We a lot of times we're focusing on X-rays and deformity and surgery and spine, and these topics are genuinely important, and I really mean that when I say it. We all kind of have an obligation to learn more about this. So thank you for that. Thank you to all of our participants. Let's see, Dr. Dadale, who's in store for next week?
In store for next week is Dr. Alpesh Patel, my partner here. He's the director of orthopedic spine surgery at Northwestern, the co-director of the Spine Center, director of the fellowship. He's professor, MD, MBA, and he'll be speaking to us about 3 pitfalls in cervical decision-making, finding simplicity in a complex spine world. So we'll go over 3 cases in details and challenging cases that probably he didn't go well, and what he learned from them, how we made them better. So it's going to be really interactive, and he's a fantastic speaker. And I want to also thank Cara for this fantastic talk. I mean, it's 6:05, and we wanted we didn't want to stop. Like, I were texting each other. It's like, that was really good and very educational, and it's eye-opening too.
Great, thank you. So Dr. Patel from Northwestern Orthopedic Spine Surgery next week. Thank you everyone, to my faculty co-hosts, the panelists, everybody that was here and contributed, and of course to the participants. Dr. Sedney, thanks again, and see you all next week. Have a good night, everyone.